On Your Health this morning, we want to bring to light a survey that has been conducted on matters HIV and AIDS here in the country, and we'll also get a bigger overview of the African continent. Allow me to introduce my well-enabled panel this morning. Seated closer to me is Dr. Joyce Wamusie from NASCOP. She is a program manager, strategic information within the organization. And on my further left is Peter Young. He is the CDC senior epidemiologist and co-investigator for CanFIR. It's so good to have you, both of you, this morning.
Thank you.
Let me begin with you, Dr. Joyce. This new survey that has been conducted by quite a number of partners, give us an overview of what it is that you have learned from it and what it tells us about HIV here in Kenya.
Okay, thank you, Zinzi. So the survey is we're actually just beginning the fieldwork component. Mm-hmm. It's called CanFIR, which stands for Kenya Population-Based HIV Impact Assessment. Right. It's the third of its kind in this country, but it's also part of a larger multi-country study called the FIR project, which is taking part in 14 countries. Already 11 are done. Kenya is the 12th, and then we will have Haiti and Rwanda. So the good thing about the CanFIR, it builds on previous population-based surveys. They used to be called Kenya AIDS Indicator Surveys, and what we have learned is, over time, every 5 years, we do need data that tells us where we are at when it comes to how we are doing with HIV programming in this country. Mm-hmm. So CanFIR has three objectives. We intend to be able to first give counties data regarding HIV, how they're doing regarding HIV programming. This will be the first time, because the previous two surveys were not powered to give data by counties. So counties are really excited by this. They will be able to know, is HIV really a problem in my county? How much money should I put in regarding dealing with this with the epidemic? And then we'll be able to also measure the impact of HIV in that we'll look at new HIV infections. Have they come down? In the last population-based survey that we did, it was at 0.45%. We want to find out, has it gone up or has it decreased? And amongst which age groups, which subpopulations is the variance being seen? And then the other thing we will want to find out is the viral load suppression. How well are our people who are living with HIV suppressing the virus? Because the lower the viral load, the better of a quality of life and quantity of life, and of course transmission is also markedly reduced.
All right.
Yes.
So given that overview for our viewers, then would we say as a nation we are in line with the 2030 goal for controlling AIDS epidemic? Are we in line? Are we gearing off a little bit, or how is it looking?
So that's a good question. The exciting thing about this is, in Kenya, we have very many data sources. And from the service point of it, because we do receive data from all facilities that are managing people living with HIV, as long as you're enrolled in care, we are able to have aggregate data that tells us how well we are doing, and we are on course. But the thing with CanFIR, the population-based survey, it will tell us from a population level. We will now be able to put together the service statistics and the population level statistics, and now be able to completely answer that question. Are we getting to epidemic control, which we intend to get there by 2030.
Right now, a number of Kenyans are not sure or haven't even heard of the 1990 goal. Yeah. Talk to us about the 1990 goal.
Okay, so the 1990 is a UNAIDS can I say, a goal that countries have adapted. And what it means really is, the first 90 is we want to be able to identify people who are living with HIV and enroll them into care. Okay. So in Kenya, we estimate we have about 1.5 million people living with HIV. And we currently have about 1.1 million who we have identified and are in care. Now, identification is tricky because it involves getting to know your status. And getting to know your status is a hugely voluntary process. It comes from the person themselves. I can't come and force you to take a HIV test. So we are telling people, get to know your HIV test, your current HIV status rather. So 1.1 over 1.5 gives us about 73% of the first 90. Then the second 90 is, out of all the people we have identified, how many have we put on lifelong antiretroviral therapy? Because we know it works. And of that, of course, we do have the test and treat approach that we launched the other day, and we have about 99.98% who are on ART. So we are doing really well, and you can only be on ART if you're in care. You cannot be on ART if you're out there and we don't know your status. And then the third 90 is about viral load suppression, very important for us, because that tells us whether we are getting to the level where we are giving people living with HIV a chance in life to live quality and quantity life.
Right.
So for that, we are at 83%.
All right, Mr. Young, as the co-investigator in this specific survey, what would you say are some of the key challenges that as a nation we are facing when it comes to attaining our 2030 goal?
Thank you. I think this country has one of the largest HIV care and treatment programs in the world. So Kenya has made great strides towards reaching people living with HIV and getting them onto treatment. Nonetheless, as my colleague Dr. Joyce mentioned, 1.5 million people living with HIV is a large number of people to get onto treatment. And making sure that all of them know their HIV status is probably one of the bigger challenges. Because, as she said, it comes from within. You know, the individual needs to want to get tested to learn their status. I think the program has done a great job of getting people on treatment once they know their status and ensuring that they're virally suppressed once they're on treatment. But one of the biggest challenges will be that first 90, which is helping people to learn their HIV status.
So and that comes with having to break stereotypes. And that's a big issue here in Kenya when it comes to breaking stereotypes. But how do we begin to have that conversation, Mr. Young, of how as a nation, because one of the things is cultural barriers. Cultural practices are such a big barrier here in Kenya, especially if you're going to go into the interior parts of Kenya. How do we begin to start having this conversation as a nation and saying, look, if we are going to achieve universal healthcare, which is Mr. Kenyatta's big four agenda, if we're going to hit the 2030 goal, we need to break down cultural practices and say there are few practices here in Kenya that are not healthy and we need to get rid of them. Mr. Young?
Well, I think related to knowledge of status, I think there are many different approaches to helping people learn their status, people who might not have otherwise gone out and gotten a test. Self-testing is something that the Ministry of Health has just recently introduced as a new strategy. That's where an HIV test that somebody can use on their own at home without a health provider present. They can use that to test themselves, learn their HIV status, and then go to a health facility to get confirmatory testing. That's one, I think, innovative strategy that will help. Other strategies that have proven very effective recently are partner notification or helping people to notify their partners about HIV and get them tested as well.
Right.
Since those who are in a relationship with somebody who's HIV infected are more likely to also be infected themselves.
Dr. Joyce, your thoughts on how as a nation we can break down cultural practices that hinder us from reaching towards the goal?
Okay, Zinzi, the whole question about getting to know your status goes even beyond cultural practices. It starts again with the individual. The individual must want to know their current health status. And current health status is actually not just HIV, it's many other things. But one of the things with Kenyans, and we even see it in our health data, is our health-seeking behavior is a bit peculiar. We like to wait for when things are really bad,
right,
for us to get to find out what's happening to my body. And the body has a lot of early warning signs. You know, you don't just wake up in the morning and you're coughing for 2 weeks and you're not wondering what's happening. So that is the first step. The second step is understanding that HIV is no longer a death sentence.
Right.
The fear that people have should be removed. It's no longer that thing that you fear. Of course, it's not an easy thing to take a HIV test. Even for me, I take every other time, but it's not easy. But you have to face that fear. We're actually saying don't fear, can fear. Because there will be HIV testing in the survey.
Don't fear, can fear.
In the survey,
Okay.
yes. So don't fear, can fear. Don't fear taking a HIV test. It's the people who know their current status that are better off than the ones who are keeping on, holding back, and worrying. Do they know? Don't they know?
There's power in knowing your status.
Yes, there is
getting.
power in knowing your status.
But Dr. Joyce, the other thing is that ARVs here in Kenya, how easily accessible are they?
ARVs are highly accessible, accessible.
Especially for those in low-income areas.
Especially for those in low-income areas, ARVs have been accessible in the public sector since 2006. There is no payment. You get yourself to the facility. You are enrolled in care. We have highly trained healthcare workers who are on top of things, who keep on being sensitized on the guidelines. They provide standard packages of care. ARV access has been there. Actually, it's when it comes to HIV status and getting onto care, the problem is really not even amongst the low income. We are talking about middle class. Do they want to know their status?
Middle class Kenyans.
Middle class Kenyans. Men are another subpopulation that we are looking for because men will go to facilities when they're really down. But women, there's always this opportunity to get to a facility, either because you're pregnant or you're taking your child for immunization. Plus, women don't keep things. Once you are coughing, you will get yourself to a facility. But the other group we are also looking at is the young people.
The millennials.
I don't know, they are called the millennials. So the young people, we keep on asking ourselves, are we meeting them at their points of need regarding when it comes to the healthcare system? So we are having conversations with the young people for them to tell us, what is it you want to see at a healthcare facility that will make you not feel like you're being discriminated against, that will make you feel like you're being met, that the healthcare worker is meeting you at your point of need.
Right. Mr. Young, Dr. Joyce paints a good example there of how that the big challenge here is both men and then the younger generation. How can we loop men into the conversation and say, hey, it's okay to know your HIV status?
That's a great question. I think men are more challenging to reach for HIV services, both for testing and for care and treatment as well, due to the fact that their health-seeking behaviors are really not as good as women. I think, through sensitization, through the media, through programs like this, I think we can re-emphasize the need for men to also take care of their health. I mentioned earlier partner notification, or services that try and reach men through their partners, and women through their partners, are another way to try to get people tested who might not have otherwise gotten tested. Those are two examples.
All right, so Mr. Young is also part of the Central for Disease Control here in Kenya. He's a senior epidemiologist, and CDC is it's international, and they're also represented here on the African continent and more so Kenya. Mr. Young, what can you tell us about now the same issue, HIV and AIDS, but now with a bigger scope on the African countries? Which countries are doing better, and what can Kenyans learn from them?
That's a very good question. CDC, just in Kenya, we have a very large program we support through the ministry's program that supports over 1 million people on ART. The PEPFAR, the President's Emergency Plan for AIDS Relief, which funds all of our HIV work here in Kenya. I think the budget annually is about $500 million just in Kenya alone. That's one of the largest country budgets in Africa. Some of the countries that have the largest HIV epidemics are Kenya, South Africa. There are other smaller countries that have higher HIV prevalence, like Lesotho, but they're very small countries, so they have very few people living with HIV living there. And in some ways, that does make some things easier. It's easier to manage a smaller geographic area. So Kenya is unique in its diversity. 47 counties, each with their own different cultural issues and socioeconomic issues, and a fairly high HIV prevalence. The last Kenya AIDS Indicator survey measured the HIV prevalence at 5.6% among adults. So it's certainly a big challenge. I think Kenya has really made great strides compared to other countries in the world at rolling out ART. I think some of the challenges that will emerge or that are emerging are drug resistance. You know, when you have so many people on treatment, you do have to be very concerned about ensuring that the treatment is effective and maintaining its effectiveness over time by ensuring that drug resistance is controlled. And Kenya does do things to do that. It has surveys to measure drug resistance. This upcoming KenFIA survey will measure drug resistance in the patients who give blood during the survey. So I think there are many things that need to be done in Kenya and elsewhere. Scaling up treatment and reaching those 90-90 goals, that's really what many countries have signed on to those goals, because one of the best ways to prevent new HIV infections is to make sure that everybody who's already infected is on treatment so that their viral load is completely suppressed and their risk of transmitting the disease to their loved ones, to others, is minimized.
Yes. I mean, it's good to hear that Kenya has made quite a number of strides on the continent. Paint for us probably how other countries are doing. You've mentioned Lesotho. How is South Africa performing? One of the biggest economies that we have on the continent and key to it as well.
South Africa is doing well. They have a very large program. I'm not familiar with the exact numbers of people that they have on treatment, but it is a very large program. South Africa is different than Kenya. You know, it's a large economy, even larger than Kenya's, and they do finance a lot of their treatment program themselves. Kenya's treatment program still does rely a lot on foreign investment, like I mentioned, the PEPFAR program, though of course the Kenyan government does also invest heavily in healthcare in general and in HIV. But I think that's something that is an ongoing dialogue, a policy discussion at the Ministry of Health, is, you know, what is the long-term picture for financing for health and for HIV? That's not my area of expertise, but I know universal healthcare is something that everybody's talking about.
Right. Dr. just add to what Mr. Young has talked about, the issue of policy. Because it's one thing for the survey will show us where the challenges and the loopholes are. And you can get as much funding as you can and people on the ground. But if we don't have policy to back that, then it will not, the magnitude of it or the impact of it would not be felt as much. As a doctor here in Kenya, what are some of those policies you'd like to see being done?
So when it comes to policy, that is one of our key mandates at NASCOP, given that we are at national level, and policy and guidelines development is something that we do. We are actually one of the few countries that we develop policies that WHO come and pick and adapt for use for other countries. So what I know is we currently we are in line. We are in line with what is out there internationally. We have the latest treatment guidelines. We have the latest HIV testing guidelines. When it comes to key populations, we are also on top. And we are currently finalizing an updated form of the sexually transmitted infections guidelines. When it comes to the monitoring and evaluation component, we are looking forward now to having a surveillance system that will be robust enough to pick even new HIV infections. That's one of the things, as we move towards 2030, it will be so key to be able to pick any new HIV infections so that now we'll be dealing with the new HIV infection as in the same way we deal with an outbreak, for instance. So we do guidelines and we ensure that we sensitize healthcare workers on the same so that they are providing the most up-to-date evidence-based kind of interventions to the Kenyans.
Right.
Yes.
I'm glad you talked about the issue of trends. One thing I would love to know is how new technology is playing its role, especially here on the African continent and more so Kenya, when it comes to fighting HIV and AIDS and reaching the 2030 goals.
Yes, that's a great question. And as I said earlier, we are quite as a country, we do pick up new things and push and implement faster than a lot of other African countries. So I'll start with what is happening of late is in the testing point. We do have now the HIV self-testing, and I'm sure a number of our colleagues have come on media and talked about it, where you get a kit and you go home and you test yourself, and then you get yourself to a health facility based on the results that you see. So that's a technology that is endearing, at least we are seeing a lot of men and young people taking up that technology. The other thing is point of care technologies. The days when we used to have to wait for lab tests to be transported to a bigger lab, and then the test is done. We are getting to see that less and less. We are getting to see more of point of care where the test is done right at, as the client is waiting for their results. Then there are other technologies.
Yes,
maybe.
Mr. Young, please.
Yeah, if I could
Yes.
add, I think another area, and especially in the area that Dr. Joyce and I both work in, which is strategic information, is electronic medical records. You know, electronic data and capturing the data at the point of care is critical. And it really helps you to have data available at the time you need it. And that's something that CDC has supported NASCOP and the counties to roll out extensively in the country.
Yes.
And speaking of new technologies, what are especially first world countries doing that we could also borrow a leaf from back here?
Well, one, I guess you could think of it as a technology. One way of measuring HIV that's very different between countries like Kenya and the West is the use of case-based surveillance. Case-based surveillance refers to treating every new HIV diagnosis as something that we measure, monitor, and follow up to understand how many new infections are happening month by month and year by year, how many are getting into care and treatment, how many are virally suppressed, how many, what are the outcomes for those patients. As it is now, the best approach to measuring HIV in a place like Kenya is through surveys like KenFIA, because they give us a picture of the prevalence and the number of new infections that are occurring, but we can only do them every 5 years. They're so large and they're expensive and complicated. They take several years to plan, so we can't do them constantly. Therefore, I think the long-term vision even for Kenya as well, is to roll out something like case-based surveillance through the Ministry of Health, where we can work with the counties to measure HIV as it's occurring and control it more effectively.
Yes,
Beautiful.
and it's not just for HIV. Actually, for any chronic disease model, case-based surveillance is the way to go. So we are looking at even cancer and diabetes and hypertension. But one of the limiting factors, and we are trying to push for it through the MOH headquarters, is we need that health ID that uniquely identifies us. Because we need to count an individual once, and not count somebody twice or thrice, so that we're able to follow from the time of the disease event all the way and identify any sentinel events that occur along the way.
Right.
Yes.
Dr. Joyce, this survey, having looked at it, a big portion of it has talked about STI, which has really come out strongly.
Yes.
Why has STI this time around been very much become vocalized?
Okay, we like to say at NASCOP we deal with AIDS and STI, so we are just being loyal to what NASCOP does. And secondly, you know, HIV is also an STI. So what we have done is we are measuring HIV per se, but we're also looking at syphilis, because we intend to eliminate mother-to-child transmission of HIV and syphilis in the next few years and join Cuba. Cuba was the first country, I think, that did that. And we've been saying in Kenya, we need to Cubanize. So the only way we can know where we are at is to do a population-based survey and tell us where we are at when it comes to syphilis prevalence. The other thing is hepatitis B is is a big deal right now, and we need statistics so that we can be able to plan more effectively for Kenyans.
Okay.
Yes.
Mr. Yang, paint for Kenyans an image of why it's important as a nation for us to know our status in terms of the impact that it has on our economy, the impact that a HIV generation, a HIV country that knows its status, and how that can be replicated into a country's economy.
That's a great question. You know, I think that the impact in FIA, in the name of the survey, really gets at how well is the program doing to make sure that everyone who is HIV infected is treated and virally suppressed, and are we reducing the number of new infections? Now, of course, if you're HIV infected and you're not being treated and you develop AIDS-related illnesses, I think you're probably not being productive. You know, maybe you're staying home, you're in the hospital. It costs money to treat people when they're sick. So it's actually more cost-effective to ensure that everybody who's HIV infected is on life-saving treatment to prevent those illnesses in the first place. So that's one of the economic impacts of HIV, is that, and I'm sure many of us remember, now it may seem long ago, but it's not really that long ago, that you could enter a hospital inpatient ward in many countries, including in Kenya, and see many, many patients who were there due to their HIV illness. And of course, that had a huge economic toll, not just on the health sector, but I think on the whole economy.
Dr. Joyce, you're nodding with agreement. Would you please add to that?
You know, we've come from where, at least when I was doing my internship, a lot of the clients, a lot of the patients who were in the medical wards at that time, they were HIV infected. And at that time is when ARVs were just getting into the public sector. And really, it was really painful to see so many young people productive, who couldn't be productive, but they're lying in bed. These days, we don't see that. These days, you can't even quite, like if you ask a young person, have you heard about HIV and AIDS? They are like, okay, we've heard about it, but they don't know what we saw. So that's how come we are at that stage of we can't let our efforts go down. We are at that stage where we need to increase and ensure that we get to epidemic control, because a person living with HIV who's on ART, actually, their life expectancy is just like any other person. So they are as productive as any other person.
One of the biggest challenges I've been able to get from our conversation is the issue of, as an individual, it's your responsibility, it is your right for you to know your HIV status. What other key way is NASCOP playing in terms of fighting stigma here in the country? And I want to be really specific, especially in counties such as Turkana, Garissa, Mandera, where probably information may not get to them as fast as a young person here in Nairobi, right?
So that's a good question. And when it comes to stigma issues, it's not a Ministry of Health initiative only. It's for each one of us. Reduction of stigma and discrimination starts with yourself. And working with the National AIDS Control Council, we do a lot of work, we do a lot of sensitization to counties, and NAC really does a lot of campaigns, media campaigns, to ensure that stigma is reduced as it should actually be zero. One of the many zeros we have when it comes to HIV programming is zero stigma. So there is a lot of that. And then working together with the county governments, they are on the ground ensuring that people get the information. And even we are going to take advantage of the KenFIA survey to ensure that we educate the public on why, I mean, stigma when it comes to HIV should be at zero, really.
Mr. Yang, as a closing remark, I'd love to know the role the private sector in Kenya and on the African continent can play when it comes to fighting HIV and AIDS and reaching our goal. Because I've heard a lot about the government, but how can the private sector play and its impact felt?
There are probably many ways the private sector can impact HIV. I think workplace programs are important to reduce stigma, to ensure that workers, within the private sector have access to testing, have access to treatment. Treatment is free through the public health sector, but free treatment is only part of the picture. Getting to the clinic is important. Gaining access to that treatment is also important. Innovation, I think you asked about technology. Kenya is really a leader in terms of innovative technology, mobile applications, new ways of reaching people and ensuring that they adhere to their medications, as well as developing new diagnostics and other technologies are great ways.
Right.
Yeah.
Dr. Joyce, could you add to that, plus also any closing remarks that you would have?
Yes, so from the private sector component, private sector is rather big, but when it comes to like health facilities, we do work with private facilities, but the ones who are willing.
Right.
We are trying to ensure that we can get in some legal way of ensuring that they also begin to report through the national data systems if they are not already reporting, because we need all data. As long as you're a Kenyan is getting to your facility for services, we need that data in the national data systems. But the other way is we acknowledge that a lot of our Kenyans go to private health facilities, and we are in conversations and collaboration with with different agencies to ensure that the healthcare workers who are there are sensitized and trained so they offer the best quality of care to any Kenyan who walks through their doors.
Thank you so much. Hopefully in the next few months, we'll be having a different conversation in regards to this when the report does come out.
Yes.
That is Dr. Joyce Omise, who is the Program Manager in Strategic Information at NASCOP, as well as Mr. Peter Young, who is the CDC Senior Epidemiologist, as well as the co-investigator for KenFair, giving us an overall view of how as a nation and really as an African continent we are performing, and we'll be keeping an eye on that report. Michael, as you've had, one of the key things here is that as men, and even more so as millennials in the African continent, it is your key mandate and responsibility to know your HIV status.
Well, that is true. And remember, last week we did host some practitioners who gave us a self-test kit. And I'm very happy to report that I did go and use it. And najijua. I'm not
Good
about
for
to
you,
tell
Michael.
Yeah, I did. But I do agree that men, normally by the time we get to hospital, it's when things are almost at a very advanced stage
As
of whatever it is, even if it's a cough.
As the social slang goes, kumedhoka. That's how you know things have gone.
Kumedhoka kabisa. So,
Yeah.
na sasa tunasema kwamba hakujadhoka, lakini show inaisha. And it's time for us to wind up. Thank you very much, Zinzi. Thank you for joining us this morning and giving us that information. But it is time for us to wind up. But before that, just that